So now we will start the symposium on the exercise physiology. So I invite first of all, greetings to all the dignitaries. I invite the chairpersons to kindly moderate the session. First of all, I'll like to invite Dr. Jyoti Manari Madam. She is Professor of Medicine, Associate Dean, Medical Education. Area of interest is teaching cardiovascular science and endocrinologist. She is attached to Pramukhwami Medical College for the last 34 years and have many publications. So I'd like to invite Dr. Jyoti Manari Madam. Okay, so now I'd like to invite the second chairperson. She is Dr. Anjali Nadir Bhatt ma'am.
Yes, ma'am, present here. Glad to be associated with this.
She is the principal and professor of physiology, Government Medical College.
Will be busy for 10.
Yes, ma'am.
Nothing. Sorry.
She is from Jammu and Kashmir, professor physiology, GMC Katwa, and she has a work experience. One second. She has a teaching physiology experience over 30 years, guided MD Physiology 8 postgraduates, and many undergraduate and postgraduate examining experience she has. Over 23 publications and presentations, member of ASSOPI, EPI, Basic Medical Scientists Association, and Physiological Society of India. She is the chairperson in physiology conferences across India. So I welcome you, ma'am. Anjali Nadir Bhatt, ma'am. You are most welcome, ma'am.
Thank you so much. Thank you so much.
Okay, ma'am. I'd like to welcome the next chairperson. She is Dr. Latika Mohan, madam. She is the head of the department and professor of physiology, AIMS Rishikesh. She is the Dean Alumni, AIMS Rishikesh. Previous appointment, she has been the Dean Academics, AIMS Rishikesh, Professor and Head of the Department of Physiology, Armed Force Medical College, Pune, and she has served as a Research Pool Officer, HAMRC, Leh, Ladakh. And she has a voluminous career. She has served as 23 years service in Army Medical Corps, has 22 years teaching experience in physiology, 3 years as professor and head, special interest in medical education, completed, she has a voluminous career, 2 years special research experience in field condition and in sophisticated defense laboratory situated at Leh, Ladakh, and has a special interest in clinical physiology and trained in a lot of this EEG, PFT, autonomic function test, etc. Worked in various capacities in medical college over the years, have extensive experience in mentoring undergraduate and postgraduate students. So I welcome you, ma'am, Dr. Latika Mohan, ma'am. You're most welcome, ma'am. Our last chairperson is Dr. Vasil A. Sheikh, sir. He is Professor Physiology in Pramukhwami Medical College, Professor in Charge PhD program, Bhaikaka University. Over 20 years physiology teaching experience of both national and international level. Publication in PubMed Index Journal, more than 100 citations. Special interest he pursues in cardiovascular autonomic function, in health and disease, in health profession, education, curriculum and assessment, undergraduate research also, and in program accreditation. I welcome you, sir. Vasil, sir. Okay. So now we will start the session. So I will first like to invite Dr. Jyoti Manari, madam, to kindly introduce the session. Ma'am, over to you. मैम यहाँ वीडियो को आ ही रहा होगा ना हाँ वीडियो आ रहा है। वन सेकेंड मैम, हमारा वीडियो तो आ रहा है मैम, लेकिन कहाँ पे है ये पता करना होगा। ये हमारा है मैम, इसको पिन कर देते हैं मैम, आ जाएगा मैम। थोड़ा सा इसको नीचे कर लीजिए। हाँ
Good afternoon to all of you. It is my pleasure to be a part of the after a very long time, online plus offline CME. The topic has been of real interest to me because I have been teaching and taking active interest in cardiovascular physiology as well as medicine. I have been a professor of medicine, and I know that exercise carries a lot of importance, but it has been not looked at that seriously by the patients. Knowingly or unknowingly, due to various issues like advances in technology, giving us a sedentary lifestyle and adding to our problems of not exercising because of the digital technology advances. So there are two sides of a coin. Positively, we are advancing with technology, but the negative effects are tremendous in the form of adding to lots of non-communicable diseases in the form of obesity, diabetes, hypertension, coronary artery disease, osteoporosis, depression, everything because of our sedentary lifestyle. Now, the topics are of real good importance as far as the exercise physiology goes. Coming to what is the difference between physical activity and exercise? Physical activity by definition is a very clearly any bodily movement produced by skeletal muscles that results in energy expenditure. Then what is exercise? It is a structured and planned physical activity, which we call as exercise. And it has been very rightly said that physical inactivity nowadays is compared with smoking as giving rise to one of the non-communicable diseases. And we are seeing lots of young, obese, hypertensive patients, lots of young adults with obesity, diabetes, and hypertension or metabolic syndrome. And therefore, we have to see that we give a good amount of importance to physical activity and exercise. I will not take much of your time. Only point that I would like to raise now is cardiopulmonary exercise testing. When we say how is it different from the treadmill that we advise to the patients of cardiac diseases. Now, cardiac rehabilitation has become a very big focus of interest following either acute coronary syndrome or even heart failure patients who are gradually given cardiac rehabilitation program. And in that process, earlier we used to just give them a treadmill or with a protocol which is revised only for cardiac patients, and gradually we increase their level of activity. With the cardiopulmonary exercise testing, we look at the oxygen demand and oxygen usage and oxygen as well as carbon dioxide output. And with that, the calculated rehabilitation program is given. And it has been proven with various papers that CPET is a gold standard in comparison with treadmill. And therefore, treadmill may give you only an assessment of the cardiac profile, whereas CPET includes oxygen and carbon dioxide demand as well as output of the two. In the COVID era, what we were very much seeing is once the patient recovers from COVID, we have to give them a rehabilitation program. And with that, we have to gradually get the pulmonary functions to normal. In the process, what we realized that 6-minute walk test was the first step in seeing whether the patient can be made to gradually exercise and come out of the COVID lung injury that the patient had. So lots of advances have happened in the exercise physiology and the tests that are given to patients who have to undergo various protocols and various diseases that they have. So I will not take more time because there are good speakers to talk about all of this. So thank you once again. Let us proceed with the conference. Thank you.
So thank you, ma'am. Now I would like to invite Dr. Anjali madam to kindly introduce our first speaker, that is Dr. Anoop sir.
Good afternoon, everyone. I am grateful to ASSOPICON to give me this chance and honor to present the first speaker, who's Colonel Dr. Noob Krishnan. He is a specialist in, or has been a specialist in military medicine for the past 23 years. He practices sports medicine and exercise physiology, has been at it for the last 13 years, and has worked in hospital administration also for the last 4 years. He has done his MBBS and postgraduate diploma in sports medicine, his PhD in sports rehabilitation, and is pursuing his PhD in sports medicine as of now. He has many certified courses and workshops to his credit, and has been ex-head and in Department of Physical Medicine, Rehabilitation and Sports Medicine in Army Hospital, Delhi. He has been venue doping control manager at various Commonwealth Games, has been doping control officer during the ICC Cricket World Cup 2011, and consultant for sports medicine to President of India. Also teaches BPT and MPT and PhD students. And during various cricket tournaments and other national and international games, he has been a part of the sports medicine team and has many anti-doping agencies also. Has about 19 paper presentations to his credit and 16 publications. Has received many awards like the Chief of Army Commendation Card 2002, United Nations Missions in Ethiopia and Eritrea Force Commanders Commendation Card 206, Vice Chief of Army Staff Commendation Card 211, Chief of Naval Staff Award for Best Published Paper in Medicine and Allied Subjects in 2017, and Best Published Paper in Medical Journal of Armed Forces India in 2018. And he has his key expertise areas are exercise testing and performance evaluation and sports injury management and rehabilitation. Is also a specialist in musculoskeletal ultrasound guided diagnosis and intervention in sports injuries, performance enhancement and sports nutrition, elite athlete testing, monitoring and injury management. And he leads a multinational, multidisciplinary team of sports scientists and is a faculty and guide for sports medicine and sports science courses. So he has a very, you can say, elite CV to go by, and I'm sure his presentation will be interesting for all of us. Welcome, Colonel Anuj.
Thank you. Thank you, Dr. Bhatt, ma'am. Thank you for your kind words and the introduction. Thank you, ASSOPICON and ISSEM for this opportunity. I would just start sharing my. Somebody will have to give me screen sharing rights, please.
Okay, sir. Okay, sir. I'm giving, sir. एक सेकंड सर. Yes, sir. Now you can say it, sir.
I hope the PPT is visible.
Yes, sir.
Okay. So good afternoon, ladies and gentlemen, and thank you for this privilege. I will be speaking on exercise is medicine, the principles and exercise prescription. Okay, so the Honorable Chairperson has already defined the slide. So basically, physical activity is something you do. Physical fitness is something you acquire because of being physically active. However, exercise is structured and tends to have fitness as its goal. What is the magnitude of the problem? More than half the physicians trained in the United States receive no formal education in physical activity. Most money is spent on treatment and not on prevention. Type 2 diabetes is a preventable disease which costs more than billions every year, and obesity costs more than 200 billion annually. These are US figures, but I am very sure the Indian figures are nothing to boast about. The prescription drug statistics, $374 billion was spent on prescription drugs in 2014. 30 million Americans were prescribed antidepressant drugs in 2014. And the US consumes 80% of prescription painkillers worldwide. To combat this, Exercise is Medicine is a non-profit initiative which was launched in November 2007 by the American College of Sports Medicine and the American Medical Association. This initiative was supported by the Office of the Surgeon General of the USA. It says that physical activity promotes optimum health and is integral in the prevention and treatment of many medical conditions. The vision of EIM is to make physical activity assessment and promotion a standard in clinical care, which connects healthcare with evidence-based physical activity resources for people everywhere and of all abilities. The goal of EIM is to encourage physicians and other healthcare providers to include physical activity while designing treatment plans. That means any treatment plan which is to be given to a patient will include physical activity as a prerequisite. If the prescribing physician is unable to prescribe a treatment plan or physical treatment plan or an exercise plan properly, he or she is supposed to refer the patient to qualified sports and exercise medicine professionals so that they can prescribe an evidence-based exercise program. There is a 4-point solution which has been given by the EIM program. Number one is systematic assessment of every patient's physical activity levels. This can be in the form of a questionnaire. This can be in the form of a verbal counseling. Number two is counseling regarding the importance of regular physical activity. It goes without saying that physician heal thyself comes first. So in order to prescribe or in order to counsel, the physician himself has to be physically active. Number three, provide eligible patients with a basic physical activity prescription. And number four, all eligible patients to receive a physical activity referral to sports and exercise medicine resources. Now, this is what is a 4-point program given by the EIM program. We all know most of this. What are the physiological effects of exercise? I would just like to enumerate a few. It decreases resting heart rate, decreases blood pressure, decreases muscle tension, improves the quality of sleep, improves immunity, and increases tolerance of heat and cold through acclimatization. Exercise improves lipid profile, improves body composition, increases cardiac efficiency, decreases bone demineralization, decreases the rate of aging, and promotes a greater sense of overall well-being. There are certain psychological effects of exercise also: improves self-esteem, improves sense of self-reliance and self-efficacy, improves mental alertness, perception, and information processing, increased perceptions of acceptance by others, reduced feelings of depression and anxiety, and reduced overall sense of stress and tension. So these are a few of the benefits of physical activity and exercise. So the next question which the patient will ask you is how much exercise? And the answer is, for disease prevention, it is 150 minutes of moderate intensity aerobic exercise per week, or 75 minutes of vigorous intensity aerobic exercise per week. Now, these are the older recommendations. Currently, the American College of Sports Medicine says for disease prevention, 60 minutes daily. That means out of 24 hours, you have to spend 1 hour in exercise. So let's start with the exercise prescription. Yes, ladies and gentlemen, exercise has to be prescribed, and exercise has to be prescribed scientifically. There is an art of exercise prescription. Number one, the first art is exercise prescription require individual modifications. That means exercise prescriptions are tailor-made. You cannot pick and choose, and one size does not fit all. When you give an exercise prescription, you have to monitor the exercise intensity, the duration, and the training progression, and it should be adjusted by monitoring blood pressure, heart rate, and RPE. Individual interests, abilities, and limitations should be addressed while you prescribe an exercise program. If a person or a patient is interested in walking or running, then you prescribe that for him. If a person is interested in swimming and has access to a swimming pool, then you prescribe a swimming program for him. So that is how these programs have to be tailor-made for individual as well as for the facilities which are available. Before you start any exercise program for anybody, always have a pre-exercise testing program in place. Look at the age of the patient, the sex of the patient, the clinical status and related medical problems. What is the level of physical activity which the patient is habituated to do? Look at his orthopedic and musculoskeletal integrity. If you feel that the physician feels required, you may conduct a stress testing program on him. Whatever program you do, make sure you have a baseline physical, physiological, and biochemical parameters tested and recorded somewhere. So how do you start prescribing an exercise program? Remember 4 letters: FITT, Foxtrot, India, Tango, Tango. Frequency, intensity, type, and time. Frequency. How often do you exercise? This can vary from several times every day to 3 to 6 times per week, depending upon the exercise intensity, time, and the schedule which you have prescribed. Intensity. Before you prescribe intensity, intensity is basically how hard the exercise should be for an individual. Before you prescribe intensity, you should always have an individual's maximum functional capacity determined by a treadmill test. And based on the percentage, that is, if you prescribe 45% of that, intensity will be low. If you prescribe 60 to 70%, intensity will be moderate. And if you prescribe around 80 or higher, the intensity will be high. If you do not have access to a testing program, you can ask the athlete or the patient to do something called a talk test. When you are exercising, tell the patient to keep speaking to himself. How am I feeling? I'm feeling fine. How am I feeling? I'm feeling fine. The point where he's unable to complete this one sentence is the point of moderate to high intensity. And this is what you need the patient to exercise at. If you have access to heart rate monitors and heart rate zones, then you may prescribe the intensity based upon the heart rate zones. These are the zones which are based upon maximum achievable heart rate. So generally, if you are between 70 to 80% of maximum achievable heart rate, you are considered to be in the aerobic zone, and anything above 80 to 90% is in the anaerobic zone. Time. How long do I exercise? Exercise should be sustained for 30 to 60 minutes for a minimum of 5 hours per week, up to 7 hours per week. When in doubt, remember the thumb rule, 60 minutes or 1 hour per day. Type. What are the type of exercise which are to be prescribed? Again, type of exercise depends upon the individual, the clinical condition, and the available facilities or equipment. It can be walking, jogging, dance, bicycling, swimming, rowing, cross-country skiing, etc., etc. When you start prescribing an aerobic exercise program, these are the things which you're supposed to take care of. Aerobic exercise frequency is 3 to 5 days per week. Intensity, moderate to high. If you want to give a moderate to high program, he should not be able to sing. That means it should not be able to complete a talk test. Time, 20 to 60 minutes. However, an aerobic exercise program can be done in pulses also. That means you can accumulate the 20 to 60 minutes in pulse doses. Type, walking, jogging, biking, cross training, running, all these are swimming, all these are aerobic exercises. Now, aerobic exercise is generally prescribed for people who are on a weight loss program, for improving cardiorespiratory fitness, and for weight loss. Resistance training. It is a very important part of the exercise prescription, and it is often neglected and misunderstood. Resistance training is safe for all age groups, and the only thing is it has to be prescribed properly and it has to be done properly. Resistance training is also called as strength training. So frequency, 2 to 3 days per week, and with at least 1 day of rest between sessions that use the same muscle groups. Intensity. You have to choose a weight or a resistance level which will enable you to do at least 8 to 10 repetitions. Repetitions is how many times you can repeat that particular movement. If you're able to do 8 to 10 reps, and at the end of the 10th rep, you're exhausted, that means your intensity of exercise is adequate. How long? You should be able to do at least one set of 8 to 12 repetitions and work up to that point when you can do 3 sets every day. And what are the type? Dumbbells, machines, barbells, kettlebells, you name it, body weight, push-ups, sit-ups, strength training, anything. You have to choose a type of exercise which will exercise the major muscle groups. And remember, when you're exercising a major muscle group, exercise the agonist and the antagonist muscle group on the same day. When we talk of exercise program, flexibility is a motor quality which we tend to ignore. So how often do we do flexibility drills? At least 2 to 3 days per week. Intensity, you have to stretch to the point of feeling tightness or slight discomfort. Time, you hold the stretch for 10 to 30 seconds. And type, each major muscle group is to be stretched during the exercise session. So this is a chart which shows you how to prescribe what type of exercise, and how to calculate the intensity, the time, and the type. Generally, aerobic exercise is 3 to 5 days a week with 65 to 90% of maximum heart rate, 60 minutes every day, and use of large muscle groups are important. Strength training is 2 to 3 non-consecutive days, 70 to 85% of maximal resistance. One set, you start with one set of 10 to 12 repetitions and work up to 3 sets. Flexibility drills are 2 to 3 days a week and sufficient to develop and maintain the full range of motion. Try and do 2 to 4 repetitions of each stretch and hold the stretch for 15 to 30 seconds. Now, we all have gone to parks in the morning and we all see a group of people who keep doing the same chakkar every day. You go after 6 months, you will see the same group of people, and it is unlikely that they would have lost any weight or gained any fitness. The problem is they do the same thing day in and day out. They forget the principle of progression and the principle of overload. When you feel your body is getting comfortable with an exercise prescription, you have to increase the load and you have to progress the exercise. How do you do that? Okay, so you increase the frequency. You can increase the intensity. You can increase the time of the exercise or the duration of the exercise. But generally, when you are doing a particular type of exercise, you do not change the type. So you play around with frequency, intensity, and time when you want to increase the progression, when you want to increase the load upon the body. This is a Filipino physical activity pyramid, just to give a rough idea of what is to be done. Physical activity, try and accumulate 60 minutes every day. Endurance exercises, 20 to 60 minutes, at least 3 to 5 days a week. Strength and flexibility, 2 to 3 days a week. And as we all know, sitting is the new smoking. So try and minimize inactivity. Okay, now we come to the exercise session or what you're supposed to do every day. You are supposed to warm up and stretch before you do any exercise program or exercise session. Generally, the warm up and stretching is about 10 minutes and about 40 to 45 minutes of the main exercise program and another 10 minutes of cooling down. This will ensure that the exercise program given to you is safe and does not cause any injuries. Scheduling of the exercise. You can do the exercise in the morning because it helps you to get ready to face the day's challenges. You can do it in the afternoon to recharge your batteries. You can do it in the evening or you can do it at night. Whatever time is suitable to you is fine. Only condition is that you should not be exercising within 90 minutes of a meal. Otherwise, you can exercise any time of the day, whatever time is suitable to you. And please understand and remember that short bursts will count towards the total time. This is a chart which helps you to overcome the obstacles for a physical training program. Number one, if they tell you we don't have time, look at the schedule. I'm sure you can find some time. You can multitask. You can exercise during your lunch breaks or during classes, or you can select activities that require minimal time. Social influence. You can invite your family and friends to exercise with you, or you can join a class. Lack of motivation, willpower, or energy. You need to have willpower. You need to write down your program in a book and you need to make time. Get an exercise partner who will make you accountable for working out. Give yourself an incentive and schedule your workout when you are the most energetic. Lack of resources. Yes, it is a big problem, but select an activity which requires minimal equipment. You really don't need expensive gym equipment to start a physical training program. You can get into mind-body exercises such as yoga or Tai Chi because they are very effective in reducing stress also. So the take-home message: exercise is a magic pill for disease prevention. Identify your fitness goals and work towards it. Design a plan for cardiovascular fitness, flexibility, strength, endurance, and body composition. Choose activities that you like. Be aware of obstacles to physical activity. Use of groups and mind-body exercises to overcome these obstacles. Pulse doses of exercises are also effective. And don't forget cross-training. Daily, do not do the same type of exercise for the same amount of time. If you're running one day, jog the next day. If you're jogging one day, swim, do cycling. So that way, ensure that different muscle groups are being exercised so that you don't get bored with your exercise program. I would like to introduce you to the Indian Society of Sports and Exercise Medicine, because as the EIM program says, you're supposed to refer your patients to qualified sports and exercise medicine professionals. Now, this is a society of qualified sports and exercise medicine professionals in India, and you can very well, we are pan-India, you can very well refer your patients to us so that they get expert care for exercise prescription. I would like to end with this quote: "You will be nearer to heaven through football than through the study of Gita." Swami Vivekananda. You will also understand the Gita better when your biceps are a little stronger. I seem to have finished, ladies and gentlemen. Thank you very much for listening.
Thank you so much, sir. It was a very informative talk, sir. Thank you so much.
Speaker is Dr. Gagan Kumar, and he is an MBBS from Medical College, Raipur, has done postgraduate diploma in sports medicine from Patiala, Punjab, and also has done his MD Physiology from AIMS, New Delhi. He is currently working as a senior resident in Department of Physiology, AIMS, Raipur, is an ex-senior resident of AIMS, Gorakhpur, and ex-medical officer of NIS Patiala. Has attended Commonwealth Games in Glasgow and Scotland as team doctor of Indian boxing. Has worked with senior Indian men boxing team and with Indian judo senior as well as junior youth team. Has worked with Indian junior youth hockey team and Indian senior weightlifting team. Has also worked with Indian archery team and athletic team walkers. Has been sports medicine, exercise, fitness, and health advisor to Chhattisgarh Pradesh Thang Ta Association and Raipur Taekwondo Vikas Samiti. Has many publications to his credit, and important ones are Sleep for Injury-Free Sports Performance and Resumption to Swimming Post-COVID. Has been a lawn tennis player and a martial art player himself, and is working in AIMS Raipur as present. Has attended many conferences and CMEs, and is a member of many physiological associations. So with his keen interest in different sports and exercise medicine, exercise physiology, and autonomic neuroscience, we welcome to you to this platform, Dr. Gagan, so that you can present your latest study. Welcome.
Thank you, ma'am. Thank you for the introduction. First of all, I would like to thank all the office bearers of ASSOPI and the organizing committee members, especially Dr. Hasmukh sir, for giving me this opportunity to present a talk here. So now I would like to share my screen. Okay. So, okay. Can you all see the screen now?
Yes, yes.
Okay, thank you, ma'am. So the theme of this ASSOPICON is recent trends in physiology. And the topic of my presentation is physiological assessment of fitness and performance using easily available tools. So as Anup sir has already discussed about the exercise prescription, and Omlata ma'am has already talked about the cardiopulmonary exercise testing. Okay, so but these CPET tools are not available everywhere. These are high-end tools and only available at like AIMS New Delhi and other institutions which has these assets with them. So what happens with other peripheral college? How can you assess physical fitness at there also? So that's what I'm going to talk about now. Okay, so I'm going to present my talk under these subheadings like introduction and the components of physical fitness and then grading of physical activity and then what are the different methods to assess physical fitness. So first of all, starting with introduction. Physical activity and active lifestyles are an integral part of healthy living, as it has been discussed since this COVID pandemic hit us all. Okay, this COVID-19 pandemic led to a lot of physical inactivity and restrictions, due to pandemic itself, and lead to the development of different diseases. Like it led to various diseases like obesity, metabolic syndrome, and all. So what is the clinical significance of exercise physiology over here? We can use it for exercise prescription in different diseases to prevent these lifestyle diseases. We can use it. Okay. So, okay. So what is the definition of physical fitness as described by Anup sir also? According to the American College of Sports Medicine, physical fitness is the ability to carry out daily tasks with vigor and alertness without undue fatigue and with ample energy to enjoy leisure time pursuits and meet unforeseen emergencies. As the definition described here, it is not only about the talk, it is not only about the task, but also about the leisure time. Okay, how you enjoy your leisure time and also how you tackle the emergencies. That is all about the physical fitness. Okay, and then what are the different tools we can use it? As ma'am has discussed, Omlata ma'am has already discussed, the tool CPET uses the oxygen and CO2. Okay, so it has a gas analyzer which analyze the oxygen and CO2 concentration in expired air. Okay, but in indirect measurements, we can use recovery heart rate or distance covered during a run test or walk test to measure a physical fitness of a subject, of a person. Okay, so I'll show you how this can be used. So first of all, I'll tell you about the components of physical fitness. What are the various components? If you talk about a normal daily living, okay, if you talk health related physical components, then these are the components. 4 components: cardiorespiratory endurance, muscle strength and endurance, body composition and flexibility. And if you talk about sports itself, then skill related like power, balance, coordination, speed and agility. Okay, so these are all the components of physical fitness. And then how can we grade physical fitness? So if you want to prescribe exercise protocol to a subject or a patient, so you can grade his physical fitness. First of all, assess his physical fitness on the basis of recovery heart rate, which you will get after the like as ma'am has already talked about the run test or walk test. Okay, so you can get a recovery heart rate or assessment of VO2 max. There are various regression equation based on various parameters of body like weight, okay, BMI, recovery heart rates. So you can also get VO2 max indirectly. Then metabolic equivalent of task. What is MET? MET is nothing but, let's take example like what is one MET? One MET is basically the baseline value of oxygen consumption. Like right now, if I'm sitting and talking, the baseline oxygen consumption will be around 250 ml per minute or 3.6 ml per kg per minute. So that is called as 1 MET. So that's how you can make exercise protocol of different MET. And it is used to be said a normal person can do exercise of around 8 to 9 METs. That is how it is described. Okay. Then rate of perceived exertion. It was first it was described by Bohr. That is what called box scale, which has a scoring from 6 to 20, then modified to 0 to 10. So whatever a person perceived as exertion is called as rate of perceived exertion. Okay. So these are the different things by which you can grade physical fitness. So if you want to prescribe an exercise protocol to a subject, what are the gradings? Like light physical activity, moderate physical activity, or heavy physical activity on the basis of percentage of heart rate maximum, okay, maximum heart rate, or VO2 max, or MET, or rate of perceived exertion. As you can see, if it is a household work or only walking, it comes under the light, okay, light physical activity. If you talk about the walking, a brisk walk, or badminton or TT, then it will come in moderate physical activity grading. And if you talk about tennis or soccer or running, then it will come under the heavy, which reaches up to the 96% of HR max. Okay, so this is how we can grade the physical activity. This is all as per American College of Sports Medicine. So what are the easily available tools we can use at peripheral colleges, and it can be used for everyone, like step test, squat test, or walk or run test. As ma'am has said in the beginning, like they use pulmonary disease patient or cardiopulmonary disease patient and assess their fitness by asking them to just walk in a corridor. So they just assess their physical fitness by that only. So we can also use that to assess the physical fitness of a subject, like a step test, squat test, and walk or run test. So there are different types of tests available, and various papers are available which describes these tests. Okay, so I'll tell you about one by one, like step test. Let's start with the Harvard step test. So Harvard step test uses basically a 20-inch step. Okay, but if you want to use this in Indian scenario, we reduce the size of the step to 16.5 inch to suit us Indian scenario, because height are less, or if you want to conduct it in the students, so height of the step test should be lower. That's why for using in students or for Indian scenario, they have reduced the size to the 16.5 inch. And the frequency of stepping is around 30 times per minute for 5 minutes. Okay, 5-minute exercise duration is maximum. And if they are doing the exercise for less than that time, then there is an equation in which they consider the time of stepping. As you can see, the index on fitness, they have written time of stepping in seconds into 100 divided by 5.5 by into pulse count. So frequency is 30 times per minute for 5 minutes, or less than that, they will take account the time in the seconds. And the recovery heart rate they are taking as the after the cessation of exercise for 30 seconds. That is between 1 minute to 1.3 seconds. They are taking the 30-second heart rate multiplied by 2. So they will get the recovery heart rate. So this is the equation by which we can tell a physical fitness of a subject. So a score, they have given a score starting from 5 to 130. As you can see, less than 50 is poor fitness, 50 to 80 is average fitness, and above 80 is good fitness. So this is the grading. Even when you get a score of fitness, you can change it into the VO2 max. There is a table given, and I just go into the Harvard step. There is a table given. You can see what is the VO2 max of the subject. Okay, this is indirect measurement of VO2 max. Similarly, Tecumseh step test. This is a modified step test of a bench height of 8 inches. So, what is the advantage of having a smaller step size? Advantage of taking a smaller step is there will be no fatigue or very less fatigue of localized muscle. Okay, like leg muscles, there will be very less fatigue of localized muscles, so that we can increase the exercise duration or actually get the maximum oxygen consumption of the subject. If you take a higher step, there is a chance that they will get fatigue easily. Rather than we are getting a VO2 max, we will get a maximum oxygen consumption that is not VO2 max. Okay, so getting a VO2 max, we should have a lesser size of step, so that localized muscle fatigue doesn't occur. So in this Tecumseh step test described by Liam et al., bench height is kept at 8 inches. Frequency was kept at 24 steps per minute for 3 minutes. Okay, and patient's heart rates were taken for 10 seconds and after 1 minute of rest, 10 seconds. Okay, so as you can see, they have taken a regression equation of maximum oxygen consumption depending on recovery heart rate and weight of the subject. Okay, so first you have only seen that the time duration, they have taken account the time duration in the hardware step test. But in Tecumseh step test, that is a modified version, they have also taken account the weight of a subject. Okay, so that's how you can get a maximum oxygen consumption, VO2 max of a subject with help of this regression equation only. Okay, indirect measurement of VO2 max. One more 3-minute step test described by McArnold et al. In 1981, in which they have taken a step of 12-inch height. Okay, and frequency capped, 2 different frequency capped for male and female. That's how 2 different regression equations were described for male and female. Okay, as you can see, they have taken the recovery heart rate starting from 5th to 20th second after the completion of the test and get the VO2 max. Okay, and they have also told that the predicted VO2 max is within the 16% plus minus 16% range of maximum VO2. Okay, so this is also a 3-minute step test. The next is described by Heathery et al. And as you can see, previously in Harvard step test and other step tests, they have taken consideration of the weight and all. Here, they have also taken in account the gender factor and then age correction factor. So in this step test described by Heathery et al., which was previously used by Tayari et al., they have used a 16 inches step, frequency kept at 22.5 times per minute for 5 minutes, and immediately they have taken the heart rate and got a regression, used a regression equation which has gender factor and age correction factor also, which are described over here. And also to get a VO2 indirectly, they have taken account the frequency of a stepping and also step height. Okay, so you can use any height of the step and just put the values in this regression equation, you can get the VO2 max of that subject. So that was all about the step test. 3-4 step test, there are many described. Now talk about the squat test. Okay, another one, squat test is also described. So like this, Ruffier-Dixon squat test. It is also called a 45-second self-test. Okay, you can do this 45-second squat test at your home and just get the data, okay, like P1, P2, and then see what is the grade of physical fitness, your cardiorespiratory fitness. What is your cardiorespiratory fitness? You can just see. That's why it is called as 45-second self-test. It was first described by Ruffier and then modified by Dixon later on in 1960s. Okay, as you can see, it is also called a Ruffier-Dixon index. 0 to 50, it has a rate index. It has a value from 0 to 15. If it is 0 to 3, the cardiorespiratory fitness used to be good. And if it is more than 15, the cardiorespiratory fitness is poor. That's why it is described as it has a significant negative correlation with cardiorespiratory fitness. So Ruffier-Dixon index taken account this calculation in which P0 is the resting heart rate, P1 is the maximum heart rate recorded during the first 15 seconds of recovery, and P2 is the 15-second average after the first minute of recovery. So just use this calculation and you can get the Ruffier-Dixon index and tell about the cardiorespiratory fitness of a subject on the basis of only 45 seconds of squat test. Okay, another one is a modified version of a squat test described by Ye et al. In 2018, in which they have used a customized squat stand and they did this testing on elderly subjects, and they have asked the subjects to do the squatting only till 45 degrees of knee flexion for 3 minutes in the frequency of 104 times per minute. And then they have used this regression equation, okay, in which they have taken account the age-adjusted recovery heart rate index and also physical activity level on the basis of a physical activity scale for elderly, assessed for 3 days. Okay, it is just basically a questionnaire in which they have assessed the subject for 3 days and then see what is the level of physical activity. So just put all the values in this regression equation and you can get a VO2 max of that subject. Okay, so what is this age adjusted recovery index? That is nothing but a recovery heart rate index divided by age. And what is recovery heart rate index? That is the test duration of modified squat test into 100 by the sum of recovery heart rate into 2. So that's how this is described by Ye et al., a modified squat test. So this is all about the squat test. And we have talked about the elderly person. The easiest way to assess a physical fitness of an elderly subject is by walk test. Just ask them to walk. So what are the different tests? Like all the tests derived started from the Cooper 12-minute run or walk test. Okay, then they have derived 6-minute walking test, Rockport fitness test, and then multi-stage incremental shuttle walk test or 20-meter shuttle run test. So all the run test or walk test started from the Cooper 12-minute run test. So let's talk about some of them, like 6-minute walking test. Okay, so in 6-minute walking test, subjects were asked to walk in a straight line of around 30 meters for 6 minutes. Okay, and just ask them to walk as fast as possible and just see how much distance they have covered in 6 minutes. Okay, so in 30-meter line, various 30-meter lines are drawn, and then they have asked to walk on 30-meter lines. Okay, and then after end of 6 minutes, they have taken recorded the total distance covered in 6 minutes. Okay, so what is the regression equation they used? VO2 max is equal to 14.986 plus 0.025 into travel distance, and then minus 0.161 into weight. So they have taken account the travel distance and weight and then come to the VO2 max. So we talked about the weight, we talked about the travel distance, we talked about the frequency and gender. So one more test is there, which is Rockport fitness walking test. In this Rockport fitness walking test, only subject has to walk for a 1 mile. Okay, and heart rate was measured immediately for 60 seconds after the completion of the test. And this regression equation used in which they have taken account the body weight, age, gender score, and time in minutes to walk, and recovery heart rate. Okay, as you can see, gender score for male was 1, for female was 0. Okay, so on the basis of gender, age, body mass index, and heart rate, they predicted the aerobic fitness of a subject or VO2 max of a subject. So this will conclude my presentation. Okay, so I have basically talked about all the easily available tools, including the step test, squat test, and walk test to assess the physical fitness of a subject. Okay, if you wanna, as Anup sir has already told about. If you want to discuss anything related to the exercise sports medicine, you can contact us at issem.in or mail us at official mail. Okay. Thank you very much.
Thank you so much, sir. Now I would like to invite Vasim sir to kindly introduce Barun H. Sharma sir, our next speaker.
शुरू करूं?
हाँ, जी sir.
Good afternoon, everyone. So we have now our next speaker coming up, and thank you so much, Dr. Gagan, for a very enlightening talk on physical fitness testing. Thank you so much. We will now continue with our talk with Dr. Barun Sharma. Good afternoon, Dr. Barun Sharma. Welcome to Symposium on Exercise Physiology. And thanks for accepting our invitation to be a part of this conference and the symposium. Let me introduce Dr. Barun Sharma. H. Barun Sharma is an assistant professor with the Department of Physiology at Institute of Medical Sciences, BHU, Varanasi, as well as a faculty of sports and exercise medicine, as well as human performance, environment and lifestyle medicine lab. He's an alumni of Himalayan Institute of Medical Sciences, Dehradun, as well as alumni of Netaji Subhash National Institute of Sports at Patiala. Dr. Sharma is currently serving as the president of Indian Society of Sports and Exercise Medicine, and has enough experience as a sports medicine specialist at Sports Authority of India, NARC Imphal, and has been conferred with Devraj Bajaj Research Award 2021 by APPI. His work on exercise device is in the process of patent registration. So fantastic work by Dr. Barun Sharma, and we are happy to have you as our speaker at this symposium. So I invite you, Dr. Sharma, to start your talk on applied and clinical exercise physiology, ACEP. Thank you so much, Dr. Sharma. Please, you are invited to start the talk. Thank you so much.
Thank you very much, sir, and all the faculties, respective faculty and senior present here, as well as the association who has given me to give this opportunity to to bring you to the world of the interventional world of the exercise physiology. Exercise physiology is not only for investigative; it has to be intervention, has to be also there. So my talk is regarding all the aspects. So I am bombarding, especially with the information, so that I will be able to motivate you all for a deeper session on each and every section, which I will be.
Sorry to interrupt, sir. You have given. Sorry to interrupt, sir. You have been given the privilege to screen your share. Share your screen, sir. Sorry.
No problem. No problem. Let me check. Okay. Chart visible है? बताइए. Is this visible?
Yes, sir. It's visible, sir. So kindly slideshow, sir. Slideshow.
Okay.
Yes, sir. Yes, sir.
Okay.
Now visible, sir.
Okay. Thank you very much. So my talk is regarding the basic research to the therapeutic intervention, because people are, most of the time we tend to forget that clinical exercise physiology also have certain therapeutic intervention. So without taking much time, because I have lots to talk, limited time. So let's basically go to the why, as part of the evolution of the human being, we all must be knowing that, we basically evolved as an endurance runner from Africa, human being, Homo sapien. That's why movement, locomotion is, intricately related with our evolution. That's why we have to be moving. Hence, the principle of the exercise medicine, the principle of the movement medicine comes into play. And this is a fine documentary which we published when I was working at AIIMS, New Delhi, as a senior resident. And going to the basic, because I am not going to talk much about the basic, because it has already been covered by different speakers. The most important point is this This graph which I made using my handmade which I used while I was doing my sports medicine there, and also when you handle handling patient, then everything has to be in your tips. So just to remember, very light, moderate, vigorous, and near maximum exercise, where you basically like 57, 64, 76, 96, 96. This is how I remember. Like for example, maximum heart rate. If it is less than 57, then it will become very light, and accordingly also. And this is just a percentage of the VO2 max, and also the med and all this stuff we have already spoken. So I'm not going to into detail of it. What is more important practically? Applied aspect is number one. If you are focusing the ATPR system, that is the force breathing system, then your exercise rate may be 60 to 100% of your heart rate maximum. Or anaerobic glycolytic system, it may you may require to exercise at 85 to 100%. And aerobic on why this is important, because when you have to train players, because the sports are dependent upon which energy system. There are sprint sports are there where anaerobic system is mostly used. So in that way, the training has to be done, because there is one principle of training that is known as SAID, that is specific adaptation to the imposed demand. Specificity of the training has to be done. That's why the knowing is not enough. You have to apply. And what about the maximum heart rate? People are using 220 minus S. The problem is 220 minus S is not reliable at all, and it was basically generated just as an assumption, not even from a regression equation. So that's why instead of using 220 minus S, there are so many different equations available. One of the equation is 208 minus 0.72 S in year. This is given by Tanaka. So you basically can use all these things, and Dr. Gagan, an earlier speaker, has only spoken on all the MAT and RM and all this thing. Another important point which we as a exercise physiologist or interventional exercise physiologist face is when you give the technical term of percentage VO2 max, then how you are going to teach your coaches or player or your patient to do exercise, because they don't have this percentage VO2 max data is there. So Carbonian formula for basically moderate to high intensity exercise can be used. It can convert the percentage of VO2 max or percentage VOR, that is the heart rate reserve or the VO2 reserve, into corresponding percentage heart rate. So by using this formula, one can easily use the percentage VO2 max formula. The application is, for example, if you want to do warm up and all that thing, then one can basically do what you call the 40 to 60% of VO2 max. Now, how we are going to do 40 to 60%? You just use Carbonian formula and convert into your training heart rate, and then subsequently you can advise your patient or a player to do that particular warm up or warm down in that the intensity zone. So again, let's going to the next one. This we have already spoken by various speakers. The most important point is fitness is not only cardiorespiratory endurance. Cardiorespiratory endurance in बहुत कुछ होता है. There are lots of there. Why this is important? Because each and everyone can can measure by using all these different parameters, and they can अगर state college में है, if they are in state college also, they can publish different papers also. Because the problem which one faces in state college or in peripheral college, they don't access to the high-end equipment. That should not be your limitation. Like for example, cardiorespiratory endurance, Dr. Gagan has already spoken different, like 20 a meter certain run test or beep test is there, and also a ergometer test, it can also be done, or simple step test. And by using that, you can publish different papers, like we have published different papers in National Prayer also, and you can in fact generate VO2 max regression equation by using the data which you have collected. So these are the different equations which we have generated, and now also the most important which happen to be the test of choice for many in this COVID time is 6-minute walk test. So we 6-minute walk test is such an easy test also, and it is it has a very high clinical significance, and in fact there is no standardized equation or normative data for Indians. So it gives a very good opportunity for all the physiologists who are basically from the peripheral colleges. They can take up this thing. Like we try to define different regression equation for 6-minute walk test in healthy North Indian males. This we have published. And another is the cardiorespiratory. I don't have to go into details because it has been wonderfully touched upon by earlier speaker. And the most important point which I want to say here is like we only focus on VO2 max or anaerobic threshold. There are so many parameters which you can use because it gives you an opportunity to publish paper also, and also for the applied aspect like isocapnic buffering, like HBB. So isocapnic buffering and all this concept has to be there, and these are also used as a surrogate marker in especially for players for endurance, endurance capacity also apart from VO2 max. So these are the different, the reason behind why we get I don't have to go into details because it has already been beautifully described. The most important is, in the isocapnic buffering, as you have already seen, the equivalent for carbon dioxide, ventilatory equivalent of carbon dioxide is relatively constant. And it's relatively constant from anaerobic threshold to the respiratory compensation point. So respiratory compensation point is another point, another data which you can play around and publish, and also has a tremendous applied aspect. Then after the respiratory compensation point, when your buffering capacity of your blood and all is not able to compensate for the increased production of the lactic acid, the carbon dioxide the respiratory system has to come into play. So respiratory increase in respiratory drive, it's basically seen here, where the VCO2 exponentially again increases, and also the equivalent for carbon dioxide also increases. Here is the point for HHV. So this is also important. So these are all important final details of cardiorespiratory fitness testing. This when we used to do in Bangalore side, Sports Authority of India, Bangalore, and this is again the clinical aspect. Unfortunately, cardiorespiratory fitness exercise testing has been taken up by the cardiology department, by the anesthesiology department. It's not unfortunate, it's good in fact. But physiology has to come into play also. Like, for example, clinical, how you are going to do clinical interpretation of the CPET in a patient. Like, these different algorithms are there. The most important concept is, if you do peak VO2 max, because we don't achieve the VO2 max in that plateau phase, it's not achievable practically most of the time. So we generally use the peak VO2. Peak VO2, if it is peak VO2, it's still normal. If it's still normal, then it may be because of the different disease. If it is low, then you have to search to the anaerobic threshold. And after anaerobic threshold, what you have to do? You have to go into the breathing reserve. And breathing reserve, depending upon the breathing reserve and anaerobic threshold, you can classify, the exercise limitation may be because of the effort dependent, or it may be because of the respiratory side, or it may be because of the cardiorespiratory side, or it may be because of the musculoskeletal side. So all these 3 points can be tested, and there are so many other different algorithms. These are the different algorithms which we use clinically also, and these are very much important. And again, going to the next one, running. Why running? Running is very important. All the physiologists, exercise physiologists, sports physiologists who are working on the field, they always get this advice of how we are going to do running, different type of running. See, I am just giving you the tips of the iceberg, where running can basically classify into the pattern like a 4 rear foot running and 4 foot running, where here the striking point, when the striking point of the gait cycle, when you strike using your heel, it is a rear foot running. 4 foot running is basically when you touch by using your 4 foot, and the barefoot. Barefoot is nowadays barefoot runners are coming up, where they said that shoe running causes this rear foot running, which has causes so many sports injuries and all this thing. So if you know the basic exercise physiology, the basic concept of this, then you may be able to apply in your intervention, like mid-foot running also there. The most important point for what they argue is regarding the rear foot is because of this impact, this force. This is vertical ground reaction force. And when vertical ground reaction force, you can see the impact peak is there here. The impact peak is there when you strike the ground with your heel, which is not here in case of the barefoot running or in case of the 4 foot running. And hence 4 foot running has been, you can prescribe the 4 foot running if the person is wants to do certain type of exercise and all this. But the problem is, if you see, the economy is also important. when you consider the endurance player, then the performance is affected by multifactorial, not only VO2 max. VO2 max तो बहुत कम है. In fact, in players, more VO2 max उतना important नहीं है. In players, what is important is the percentage of utilization your VO2 max. That is more important. VO2 max is basically more important for our layman, common people. For elite players, the percentage of utilization of the VO2 max or the lactate threshold, different type of lactate threshold, that is more important. So, and another important which is basically dependent upon your technique is the economy. But the different studies point at the forefoot running and the rear foot running, that doesn't have much difference. And when you see actually the clinical profile, when you can see that in case of the rear foot running and in case of the non-rear foot means mid foot or forefoot, then the injury of the ankle foot will be higher, but the knee will be higher in case of the rear foot, the low back and all these things. So if a person is suffering from a knee injury, if a person is having some scene problem, that is MTSS, medial tibial stress syndrome, or back pain, low back pain, then the forefoot running or barefoot running or midfoot running tends to be a little bit beneficial. So this is the applied aspect of the knowledge of running. Another important point of running, which we have described nowadays, many people, weekend warriors, they ask one thing: slow running. So depending upon if you decrease the speed of your running, because what is the aim of our doing exercise? The aim is in order to maintain fitness, because we are not going to play into Olympic and all this stuff. So the aim is different depending upon the aim. For common people, low running is, or methadone running, or MAF, that is maximum aerobic function running, is a type of the running which is becoming very popular nowadays. And I think that all the physiologists must know all this applied aspect. So this is the equation which graph which I basically plotted, and this is the heart rate which has been described by Dr. Meffeton. Dr. Meffeton is a doctor who invented this running, but his concept was he used only one specific heart rate, 180 minus your age in year. You can minus by 5 or 10, or if you are experienced, then you can increase by 10. And this become your higher range, and this become the lower range. If you minus that by 10 beat per minute, then it will become your lower range of your exercise heart rate zone. But the problem is that the main aim for methadone was to increase the fat oxidation. What do you mean by fat max? Fat max is nothing but 50 to 70% of VO2 max. It is the reason of where your maximum utilization of fat is there. Because you must be knowing fat can only be utilized in presence of oxygen. Beta oxidation of the fatty acid in mitochondria, whereas the carbohydrate can be utilized by using anaerobic metabolism also. So in order to use fat, oxygen has to be there, and oxygen means slow running has to be there. But how much should be the intensity of the exercise so that you have the maximum fat oxidation? So this is the maximum 57 to 70% of VO2. You can easily convert it into HR max also, which I have given by using the different formula like carbon formula. And if you plotted this graph as a percentage of the maximum heart rate, the heart rate for different age as prescribed by Dr. Meffeton, then this is basically the graph. As you know that maximum heart rate can be 220 minus S. This is a 220 minus S. And it can also be by using, what we call, let me check. So this is the blue one. This is 220 minus S. This one is the basically which was proposed by the Tanaka. So you can see that even if you use 180 minus S in here, then you may not be performing your exercise in the moderate intensity, or it may be you may be entering into the vigorous zone. But the good effect about by using this fixed formula is when you increase your S, then what will happen? Your percentage of maximum heart rate intensity will be decreased. That means you will not be having too much load to your heart. Again, what is important is if you analyze the biomechanical the analysis, this is the basic biomechanical analysis. As you increase the speed of the running, what will happen? Then you will have your both feet will be floating. The amount of the time where your both feet is floating in the air, that is known as float phase, or the air phase. That will be more. That will be more, and because of that, what will happening is if the ground reaction force, the force which is acting on your joint, of the lower limb will be, it may be increased. Like if you are running at 7.2 kilometer per hour, then it can be 1.5 times your body weight, or 25.2 kilometer per hour. It may be 3 times your body weight also. For example, running as a rule of thumb, has always the weight acting on your joint is more than 2 times that of walking. So what is the applied aspect? The applied aspect is if somebody comes to you, says that he want to do running and all this thing, then you can start the methadone running prescribed to him, or slow running also. And for a enthusiastic, for a younger or who are more applicable or more experienced, then you can always prescribe the high intensity interval training or sprint interval training. So I'm not going to speak on all these things, because it is this is the basic information which I presume that all the physiologists must be knowing. So next, going to the next one, resistant training. Let's see the resistant training. I don't know why it is here. Resistant training. Now let's go to the resistant training again. Let me check. Okay. 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 So let's go to the resistant world of the resistant training. Here, the most important concept of the resistant training, because people are always neglect the resistant training. But resistant training has far more clinical importance, equal to or even more than the aerobic training. Then if a person comes to, if a gym goer comes, or if you go to the gym, then you must be doing the basic terminology or basic exercise prescription principle of the resistant training. Like this one, this is the most common. For example, if a person is more interested, strength training has, see, one thing is the specificity, is principle of specificity is always there. So your aim may be strength development, power development, hypertrophy, like for bodybuilders, or it may be muscular endurance, not cardiorespiratory, muscular endurance. So depending upon your goal, and what should be the exercise prescription, this is the basic guideline. And since there is an individual principle of the individuality is there, so this is, you should take just this just as a rule of thumb, and not as a whole. And you have to modify according to the person. But the general rule of thumb is there. If your maximum, suppose if you are targeting power, then what will happen? Then power and strength, the most of the time, what we'll do is the load should be higher a lot. What is mean by RM? RM is a repetition maximum, 1 repetition maximum. What do you mean by 1 repetition maximum? 1 repetition maximum is the amount of the weight or intensity of the resistance training, or amount of the weight, suppose in a layman term, amount of the weight which you are able to lift, maintaining all your form only once. 1 RM, repetition maximum. How many times? Only 1. That means you are able to lift that weight only by 1 times. So this is just like a heart rate maximum where we use, or VO2 max maximum, VO2 max where we use for exercise prescription percentage of it. In the same way, resistance training, you can use the 1 RM percentage. Like for example, if you are approaching the 1 RM, then you are training for strength. Then if you are focusing more on the speed control, if you are focusing more on the speed, then you are training more of power, because power is what? Power is force into speed. So strength is the force. So then you are focusing on the power. What about hypertrophy? Hypertrophy, this is the most common question asked by any gym goer or bodybuilder or coaches. Then what should I do in gym so that I may target my hypertrophy? Then these are the basic principle, where the most important, you don't have to load, the load need not to be very high, and repetition can be 6 to 12 times, and set maybe 3 to 6 exercise. So in one set, there may be 6 to 12 repetition of the exercise, and you may do that particular set for 3 to 6 times. And the rest interval between the set may be 30 to 90 seconds. So in this way, and most of the eccentric component we focus generally do slow. Why? Because of the chance of the injury is very high in case of eccentric, because everyone must knowing the force produced, because in addition to the active force, the passive force, passive tension applies when you do eccentric training. That's why eccentric force is very high. It may causes your muscle to rupture. And by using this simple enhancement principle, which we already studied, and what is important is, your madam has also spoken. So by just using this principle, you can hit the body also. Like suppose if you want to do, if you want to target your type 2 fiber, then the intensity as the force production has to be very high, right? Suppose if you want to target type 2, but you don't want to live very high load, then what will you do? You have to bring fatigue into the play, because fatigue, when fatigue is there, And you must be knowing from the basic exercise muscular physiology that when fatigue is there, then what will happen? Then your recruitment of the higher threshold, that is type 2 fiber, will be increases. So if you bring fatigue into the play, then you will be able to recruit type 2 fiber also. Now this principle is also used by different training concept that is known as blood flow restriction training and all that stuff, which I am not speaking here because it is entire field by itself. But the most important point which you have to remember is focus on strength training. Strength training is extremely important in case of the runners also who require high VO2 max, because the injury preventing capacity of the strength training is extremely good. And going to some applied aspect, I'm not going to talk about all this stuff, but the most important point which I want to say here is this is the yeah, which I want to speak here is the eccentric training. Why my focus is on eccentric training? Because eccentric training is the training which is more focused by bodybuilders. Why? Because it leads to more, stimulation of the satellite cell in the muscles, which will lead to the more hypertrophy. But the problem is, as I have already told you, the eccentric training will has the force will be very high if you do high velocity. That's why we always do eccentric training with a low velocity, and because of the high force production, the chance of the injury is very, very high in case of eccentric training. And DOMS, delayed onset of the muscle soreness after 24 or 48 hours, then it will be there. So you have to be taken that this is the basic graph which we force into velocity graph, and it has a practical application. That's why I want to show you. That's why when you do eccentric training, we always do slow velocity. Why? Because the force is very directly proportional to the velocity. This is the point which I want to focus. By the end, the strength eccentric training is the basis of the plyometric training, stress shortening cycle. These are very important for sports medicine expert as well as the interventional exercise physiologists. And the important concept of the practical application of this eccentric training is vertical jump. The vertical jump which you can do, and you can publish different papers also, like we have published, and these are the different we can vertical jump. The amount of the high jump by the particular person is directly proportional, or it is a predictor of mortality, increased mortality and morbidity. And by using different anthropometric marker, you can predict the vertical jump also. So another point which I want to say, which people, most of the time physiologists, they don't, which we then don't go into this field, is the strength curve, the concept of the strength curve. The strength curve is when you lift a particular dumbbell or particular weight, then the amount of the force produced by isometric force produced by the muscle varies according to the joint. What is the practical application? Practical application is if you see a multi-joint exercise, like suppose it's a bench press, multi-zone exercise, then it has a ascending strength curve. That is, in the starting of the exercise where your range of motion is very low, then your ability to produce force is very, very low. And what is the practical application? Practical application is if you want to load this part of the muscle, that is when your elbow joint is almost extended, then what will you do? You have to increase the weight, because weight is fixed here. By using this chain or this thing, where the weight will be added by gravity, not in the initial phase but in the higher phase. Just by knowing this concept of strength training, you will be able to do more effective all-round training, all the range of motion training. It's possible. And the same thing also, injury usually happen. When does the injury happen? This eccentric contraction is happening of factor release, and you can see that the injury happen where? In the initial phase, where your ability to produce force is very, very less. That's why the sporter has to be very careful in this particular frame. So this is the applied aspect of being a interventional sports and exercise medicine and physiologist. So another important point which you can easily do is the measurement of the strength training, strength curve. Unfortunately, classically, strength curve is basically measured by using different dynamometer. There is isokinetic dynamometer like this one here. You can see this is the isokinetic dynamometer where you can measure the hamstring and the quadriceps strength curve. So, and it is very cumbersome, and it is mostly focusing for one joint. What you can do, you can produce your own thing. You can a type of the desi style of strength curve by using easily available thing. You can use a dynamometer, and you can measure the EMG, and all this thing you can easily do, and you can measure the strain curve. See, strain curve, and the optimal angle of 90 degree of elbow, where the maximum isometric force is there, you can call it as a optimum angle. So this may be you can use this as a practical also.
Not getting your audio, Dr. Varun.
Hello.
Can
you hear me? Okay. Okay. Thank you. So we have
try to finish also. We have to,
okay.
Have to wind up.
Sure. So this is the concept of the IEE. Then let's go to the next one, which we have already spoken. The problem is anaerobic testing is usually we forget. And there are easily available method also, like RAS training is there. By using this, you can publish different papers also in the same way, like we have done. Simple, easily available tools you can do. And now let's go into the interventional aspect of exercise physiology, like sports medicine.
Sorry to interrupt,
like
sir.
medicine.
Sir,
Yeah,
sorry
please.
to interrupt, sir. Kindly conclude.
Okay, sure. So, let's going. So this is basically the interventional aspect of the exercise physiology, sports and exercise physiology, where one can work as a sports and exercise medicine, as well as your concept can be very useful for space and aviation medicine, also for high altitude medicine also. And also the most important, lifestyle medicine. And I hope all the physiologists working in different medical colleges, please establish your own lab. And if you don't have any instrument, no problem, you can do interventional aspect by using different principles, and you can do clinical service also. So let me conclude here, because I have lots of speaks, but because of lack of time, so I'm concluding here. Thank you very much.
Thank you so much, sir. It was a wonderful presentation, sir. Thank you, sir. Now, I would like to invite our chairperson, Dr. Latika Mohan, ma'am, for the concluding remarks over the Exercise Physiology Symposium, ma'am. Ma'am, kindly come.
So, good evening, all of you. And first of all, a big, wow and round of applause for the team at Karamsad. They have done it again. They always are par excellence. Even today, I really deserve a compliment for what they did. Now, for this symposium, I must say it was first and foremost thanks to the team at Karamsad that they put me in the symposium, which I should listen most carefully to, because I need this exercise intervention the most myself on a personal deal. So it was very relevant for me, and I listened really very carefully. And the first session by Colonel Noob Krishnan was brilliant and absolutely, specific to the point. It was excellent. Very well followed later by Omlata, where she introduced us to the principles of exercise testing and simple mechanisms to do it with Dr. Gagan. And after that, I think Dr. Barun it was like, as he said, very specifically himself, bombardment. It was really wonderful. So it was an excellent symposium, and I feel that all of you should put material that you have done, put in this symposium together to make a book or a simple booklet which you can share with the younger physiologists because there's wonderful material here and very specific. So it's a great opportunity to put it all together. Now, just to say a few things I would like to say, like what has happened in the last few decades is that the opportunities for natural exercise has been replaced by various forms of mechanized, simple things which are supposed to simplify our life. So we've got lifts and we've got washing machines and we've got mixies where we would be pounding to get that natural resistance exercise. So the thing about natural is that it is natural. So it doesn't beyond a point overstrain your ligaments or your muscles or doesn't produce injuries of a particular type because you naturally sort of contain it. So when it comes to interventional exercise physiology, you really need to know what you're doing. And when you have to give a prescription, I think one has to think in terms of what are the constraints that if a person is obese and has got orthopedic problems, he is exercise deprived for a reason. So you have to bring him out of that. You have to bring him out of that pit he's in and develop the exercise and keep improving and progressing on the exercise prescription. It's not just a thing that you can theoretically talk about. So we as physiologists, this is the opportunity to come out and in his talk that you have to modify, keep progressing and keep improving, and that's how you can be really effectively an interventional exercise physiologist. And it's a great opportunity for the younger physiologists to get into a field for them to get into. But you just look at the trainers and the physiotherapists from where they are starting. You have to know the muscle groups, you have to know the constraints of the muscles, and especially people with comorbidities and illnesses, how you can develop those and build them up and bring them to the point that they can actually follow a prescription that Dr. Anoop was trying to say. So it's many of the older people or the obese people or the people with osteoarthritis can't do that level of exercise immediately. It has to be brought up. So can we have a few questions if anybody has anything to say? Otherwise, it was absolutely there's not much as far as the chat is concerned. Everyone's just praising and saying it was an excellent session. And so anything that any of the other chairpersons would like to add? Otherwise, we can conclude this session. Excellent show by all of you. Wonderful. Thank you so much.